A recent survey, actually done last year by UNICEF, of its staff, polled UNICEF staff all over the world and asked what they thought was the #1 threat to child survival. And the poll results were kind of startling because they overwhelmingly said it was the widening wealth gap in the world, within countries and among countries. Since the 2008 financial crisis, that has actually worsened even as we have seen the middle class rise as a global percentage as well. And McKinsey Group calculates up to $32 trillion, representing the wealth of only 100,000 people, has been taken out of liquidity, removed from the global economy, and hidden in tax havens and in the purchase of non-liquid assets. So what we're seeing is more and more of global wealth concentrating in the top 1 or 2% wealthiest in one society after another. If we look forward and try to imagine decades into the future, we either stay that trajectory, and that gives us one scenario for health and for how societies work, whether there's cohesion, et cetera, or we try to envision some way that that economic structure is upset, is overturned. And what would that look like? So Richard Horton, you've revolutionized your publication, The Lancet. One of the things you've done is turn it from being the world's top medical research publication to, yes, medical research, but guess what, world? There's global health. So why don't you take a stab at this question?
Well, thanks, Laurie. I mean, perhaps first of all, a caveat about your lovely phrase, the folly of imaginings. There was a fabulous paper published in Science earlier this month that was called The End of History Illusion. By looking at 19,000 individual experiments with single people, what they did was they discovered that we all have a terrible flaw. It's a flaw we all know about ourselves, which is that we massively underestimate the magnitude of change that's going to hit us in the future. And we overestimate the stability of our world. Why do we do that? Because we all think we're wise, beautiful, and admirable human beings, that we've reached a kind of exalted state of understanding and knowledge about our world. And of course, that's totally wrong. We're completely ignorant, really, about what the future is going to be. So everything, in answer to Laurie's question, that I'm going to say is a massive underestimate. But to try and get to this answer about this huge disparity and what the implications are for global health, very briefly, I think there's a political predicament that we're going to face, and President Lagos talked about it earlier, and it's critical. There is a friction that's taking place between two immensely important social forces of education and communication, and that friction is igniting a series of social movements in regions, in countries, and globally. And those social movements are catalyzing a demand for aspects to our lives, such as education and healthcare. Let me just give you one example from this country. Some of you in the audience were privileged to be at the Health Systems meeting in November, held in Beijing. And Minister Chen Zhu gave one of the plenary lectures. And he was talking about health system reform in China. And on one of his slides, he put up 2 words about why health system reform, one of the reasons why health system reform was taking place here. Those 2 words were political stability. The demand by the Chinese people for universal health coverage, for universal access to high-quality care, is a huge political issue. Yes, for the intrinsic value of health as a commodity in society, but also as an instrumental value for, in his words, political stability. So communication, education is going to create a social revolution movement for universal health coverage. Quickly, second, there's an economic predicament that we face. And that economic predicament, and I want to go broader than climate change, and it's this notion, I think, that we need to get rid of the concept of global health and talk about planetary health. And it's Johann Rockström's idea of planetary boundaries, that we all live within a safe operating space. And some of that safe operating space we are transcending, and climate change is one of those. But there are other things too. Ocean acidification, nitrogen phosphorus cycles, biodiversity, there are many of these. And this idea of planetary health, that we have to think not just about health and our economy, but the notion that a healthy population is going to depend upon a healthy planet. So I think there's a massive transition in terms of thinking about the planet, not just the population. And lastly, there's a social challenge. We published the Global Burden of Disease in December, and there were 650 million results in that. Let me give you one. One result. The number of people who died in 1990 were 47 million. Death rates from 1990, the expected number of deaths in 2010 should have been 70 million. It wasn't. It was 53 million. So we have, in 20 years, achieved enormous success in reducing death rates from disease. And yet, still, total deaths, 53 million, are going up over those 2 decades. What's driving death in the world today? 2 things: population growth and population aging. And 2 aspects to this that are very, very important. Population growth means that actually we are seeing increases, to take one example, increases in child mortality and newborn mortality in many countries of the world, especially in sub-Saharan Africa, not reductions, as is often the projected message. And secondly, an aging society is driving disability. And these 2 forces, I think, of growth, population growth, and an aging society creating disability are going to create a revolution in the way we have to think about health and the provision of health services. It's not just about saving lives, it's about investing in children, in adolescents, for human capital, and as Sudhir talked about at the beginning, human capability. And I think those 3 predicaments, the political, the economic, and the social, are going to be the crises that come from that disparity you talk about, Laurie.
Well, we're going to get to demographics in a minute, but let me come back, push you a little harder, because survey after survey in countries all over the world shows that if you ask people what they think, quote unquote, good healthcare is, they tend to describe what the elite is able to receive. So they describe good healthcare as, you know, quaternary bypass surgery and an elite facility, blah, blah, blah. What they don't answer is good healthcare is that the mean standard of health of a whole society, of a whole population, rises. And it may explain why Americans continue to believe that we have the best healthcare system in the world, despite all data to the contrary. So if you imagine forward and try to think about balancing the emergence of new scientific innovations that become available to the very wealthy and this wealth disparity question, where does this take you?
Let's not underestimate the power of people. I think too often in medicine, we think that the average is good enough for people. If you actually go out and you talk to people, and many people have done surveys in low-resource settings, actually, if you're offering 2nd- or 3rd-rate services in coverage, that's not good enough. People want high-quality care. And I think what we have to do in thinking about universal health coverage, it's not universal coverage for 2nd-class care. We have to have high-quality care, and I think that's where the revolution in education and communication is going to ignite this social force that is only just beginning to hit us. 2nd class isn't good enough anymore.
Well, that's a good segue to Rachel Duan, because first of all, I have to say earlier there was some discussion in the previous panel about women's education, women's rights. I have to say Rachel's awesome. She started out in accounting, and now she's the CEO, right? She broke through the glass ceiling at GE. And GE Healthcare is about trying to imagine new technologies, new innovations that tend traditionally to go to the elite first and then trickle down as they become cheaper and as societies are willing to pay for them to more and more of society. Do you see that being the trend in the future?
I think it's changing, Laurie. It is true that GE and GE Healthcare is a technology business. However, our investment in technology, the strategy has evolving as we understand the market needs better. It is a fact, actually, for many years, if you look at GE Healthcare, probably I would say 85% of the business is concentrated in the developed markets, which is US and Europe, okay? However, in the last few years, let's just say last 3 to 4 years, the emerging markets that including China, India, Latin America, Africa, Middle East, has been really growing at a pace double or tripling the rate. So when we are having more presence locally in those markets. It helps us understand the market needs in those markets are very different from the developed markets. I run the healthcare businesses in China, and let me just take China, for example, okay? China healthcare market is a very bimodal market. On the one hand, we have some of the most advanced hospitals. Their needs is no different from like Stanford, UPMC, like United States. And for many years, we've been relying mostly on the imported advanced technology developed in the United States and serving these customers in China. However, with the new healthcare reform that the government started in 2009, it's all about addressing the uneven distribution of the medical resource and how do we bring affordable healthcare to the rural sectors in China. So we are changing our strategies as well, Laurie. One of the things we specifically are doing in terms of technology investment is we are ring-fencing our R&D money. Specifically, we have this terminology in GE Healthcare called in-country for country. Okay? What does that mean is each year we spend about 6 to 7% of our total revenue in R&D globally. We actually ring-fence about $150 million for actually doing product development in a country like China, just for the China markets. And we've been benefiting that tremendously. In the last 3 years, we've launched 20 new products specifically designed in China for primary care China markets. So I think that's the first thing we're doing is you have to ring-fence the R&D money so that because some of the revenue is not immediate, but I think you can see the potential as the rate is growing. The second point I want to make is that with the 20 products we're launched, we're also seeing the evolution of the technology playing. That's where I probably disagree a little bit, Laurie, your comments. I think affordable healthcare and cutting-edge technology, they are not in contradiction with each other. And in many cases, we can make it work. I give you an example. Very first in-country for country development NPIs in China, it's all about cost takeout. Okay? So 3 years ago, we launched our first single-use slide CT in China markets designed for county-level hospital. We did not take a ultra-premium technology platform. Instead, we took a one single-use slide. Think of that car, okay, BMW 7 Series versus a Mini Cooper. Okay? So basically, drastically take the cost out in order to serve the county-level hospital, which typically are a little bit constrained financially. Okay? So when we launched it 3 years ago, it was a hit because 60% of the buyer is first-time buyers. It's a county hospital. But that product is all about cost takeout. However, I'll give you another example, which we just launched last November. It's a tele-ultrasound. So essentially is we marry healthcare IT technology and embed that with our ultrasound machine. What it does is it allows a county-level hospital doctor to instantly upload dynamic ultrasound image from county to actually a faraway provincial level hospital, let's say in Beijing. What's the problem we try to address? Because if you look at China, it's actually easy. The government invests money to upgrade the facilities and buying equipment for the hospital. It's easy to upgrade the infrastructure and hardware, but the doctors or lack of good doctors in a rural area is something that you can't really solve by just investing the money. So, but technology can help. When you have a product innovation that allows you to do remote diagnostic without the patient leaving the county, it actually really helps. So in that case, it's a perfect example. You're really marrying affordable healthcare with actually cutting-edge technology. So actually, we're doing a lot more of that in the next few years.
This is fascinating because the way you're describing the process, it goes right to the question of what is a corporation going into the future? What is a company, and how is a corporation or a company related to a state, an individual, a community? You're describing a whole product development process that reflects the needs of a particular state, right? So if you imagine out 50 years, I'll make it easy on you, much less 100. What is a corporation? What is a multilateral? What is a multinational? How do all these things integrate and relate?
Yeah. Well, I wish I could.
I wish
I could tell for certain. But usually, you all know probably GE is a 130-year history of company. I wouldn't say in today's world that history can predict the future, but I think it would be a good reference point. You would agree with that, right? So if you're looking at where GE started, it's Thomas Edison invented the light bulbs. And then we also invented the first world like X-ray machine. And today, it diverged into energy, healthcare, aviation. So I think one thing I do know for sure, I think in 50 years, Laurie, probably GE will still be in the technology business. The portfolio may change. You know, I do believe that in 50 years, we will be in healthcare, but the technology, how it evolves, I think the mega 10 trends we talked about early, and we're going to have to, as a company, to evolve around that. And the second one is, what's the corporate responsibility? I think at least today, we still have a few, responsible for our shareholders. It's probably not going to change. However, the way we make it work has to change, because today's world is so dynamic, and nobody really can predict what the future look like. So we need a lot more open, collaborative way to really collaborate with the different key stakeholders in the ecosystems. And GE Healthcare is doing some of that. I give you a few examples, okay? On the technology innovation side, some of the innovation, they're really very time-consuming, very dollar intensive, and very longer return payback. Sometimes in company, we do have to make trade-offs. Do we do that, or do I do actually more shorter term, easier to make the money return on it? Then what do we do instead? We actually look for industry partners, okay, and collaborate on the technology development. As you probably, some of you have heard about it, GE has a joint venture just launched a couple years ago with Microsoft. We actually wanted to bring our core expertise in the clinical area and marry that with Microsoft IT to really kind of explore what the future healthcare delivery system on informatics information. The second type of area, collaboration we do is really with industry association or government. Like in China, I'm probably most familiar with. I'll give you an example. I mentioned the doctors, or good lack of doctors is really one of the key challenges the primary care in China is facing. So instead, in addition to actually providing technology solutions, we signed a 3-year collaboration agreement with the Chinese Medical Doctors Association last year to really targeting training rural doctors for about 5,000 in the next 3 years. We've done 8 provinces, 1,200, and then we're going to continue to do that. And these are really irrelevant whether they are buying GE machine or don't, okay? And then the other example is we also partner with NDRC, which it basically is the microplanning arm in China. And they also have a health reform office under NDRC, really to explore some of the primary care model or business model. So for example, the first primary care show sites model we piloted last year is in a very poor province in China, in Gansu, really piloting how do we connect a 3-level hospital, county and township through technology innovation, basically doing the remote diagnostic instance through the example I give you on the ultra-telecom. And I think we wanted to do more of that. Now, I think the challenge, Laurie, is that I think the future, probably the solution on technology is not really going to be a barrier because you see so many industrial collaborators. I think come down to it is, can we have the right regulation and policies, because sometimes you have to break down a system in order to make the commercial model works. So that's inevitable for a corporation. For us to be successful on some of the technology, we need to have a more open system to work with the different stakeholders, including government agencies.
Well, you alluded to a lot of intimate ways that your company is working with the Chinese government and various Chinese agencies. And of course, one key feature of that is China's driving demographic future is an aging society. Yes. Where right next door you have India, and it's an absolutely opposite demographic picture. So you would look at that country in a different way as a company. And I think it's interesting because when we talk about the demographic future, there's a tendency to emphasize the aging societies and to forget that there's other parts of the world that are going completely in the opposite direction and turning into youth societies, topsy-turvy. Miriam Were has been thinking a lot about this problem, and she is probably the most successful innovator of the community approaches to medical delivery and medical care in the world today, and a recipient of the Noguchi Prize, I'm particularly proud to note. So Dr. Were, how would you vision this future, looking out decades into the future, of the demographic impact?
Thank you very much, Laurie, and thank you to the Rockefeller Foundation for this opportunity. I'm going to make some comments based on the demographic revolution. because I think we could learn a lot from observing what we can learn from the demographic revolution or structure, and we don't always do that. So as we look at the demographic structure in economic terms, we come across what has been called the bottom of the pyramid, the bottom of the pyramid. And when you look at that section of the population structure, you find that those people in the bottom of the pyramid, you know that the structure is usually, the population structure is usually a pyramid. And the people at the bottom of the pyramid are people living in abject poverty. So one of the things we can learn from the demographic structure is how can we deal with this issue of poverty? How can we reduce, minimize, eradicate the bottom of the pyramid in terms of people living below the poverty level? As you know, the book Spirit Level, which I think most of you know, has made, I think, a convincing case that if we are equal, if there is equity, it is good for all of us, not only for the poor, but also for the rich. And it makes a case in a long, which I will not go into. So the whole issue of poverty, as we can deduce it from the bottom of the pyramid, is an issue that I think should concern the world, not only those regions of the world which are under the poverty, but all the world. Because I think that one of the challenges we are going to be getting from in the next 100 years is going to be that we are members of one family. Not only human beings, but everybody on this planet is going to be affected by each other's actions. So how can we actually eradicate, reduce, remove people living in abject poverty? Because I think if the proportions of people living in abject poverty grows, it will affect all of us, I think, negatively. So that's one issue that I learned from this. The second issue that I learned from looking at the population structure is the fact that we need to retain the element of community. If you look at the population structure and you describe the kind of, as it has been said already, more people are going to be living in the cities away from the communities as we move towards the 100 years. But even if it is in the cities, how are we going to retain the sense of community? I think the sense of community is very important for our well-being. And again, this book, Spirit Level, among other many books, have shown that becoming well off is not necessarily becoming happier. And in my own analysis, I have found that not becoming happier has to do with the sense of isolation. So this sense of isolation from other human beings, the lack of positive interactions, how are we going to retain the community as we move into the 100 years? I think that that is an important element that we need to look at and say, the communities where they exist, how can we retain the community, and how can we respect and involve people in the community? I was interested with the president. He said that it's not only democracy, but it's participation that is going to matter in the future. So how are we going to involve people in communities, both in the urban communities, but also in the rural communities, the peri-urban communities? How are we going to retain the sense of community in the next 100 years? The third point that comes to mind is, of course, women and children, the vulnerabilities of women and children. And as you know, the Secretary General just talked about them as he was opening the summit for us. How are we going to look at the women and children? As you know, there is a global strategy for women and children, which we are hoping that will meet MDG 4 and 5 and part of 6. So what kind of efforts do we need? How involved are we in helping to make the lives of women and children, to reduce the death rates among the women and children, and also to increase the well-being, maternal well-being, and so on? So these are things that we can learn from the demographic structure, because if you look at it, you can see how many women there are, how many children, and the kinds of deaths that occur from that one. And also from the demographic structure, you can learn the proportion of youth. Now, if you put all the youth 10 to 25 years of population in the world, you will find that it is a lot of people. Youth as a category is a lot of young people, a lot of people. But we don't always plan for them. I can say that in Africa, this is one of our big worries. Youth who are neither in school nor in employment, nor in the farm. So they're just sort of loitering around, and we need to think about them because a lot of healthy, underused youth become a danger to everybody else. They will get into difficulties, they will get into problems of alcohol, and so on and so on. And so how are we going to deal with the issue of youth? Again, just learning from the demographic structure. What plans do we have to have empowered youth that can make use of their lives to contribute to community rather than to threaten community? And finally, I just want to make the point that, everybody wants a good life. Everybody wants to have a good well-being. But you cannot have well-being, without developing yourself. And you cannot develop yourself if you're sick. You cannot contribute to development if you're sick. Sick populations don't bring about development. So it's a challenge, not only for the sake of health, but for the sake of development as a whole, especially in those areas where the burden of disease is still very high. How do you develop unless you first look after and take care of high levels of morbidity? And finally, Laurie, I just want to make the point that for me, I'm 73, so for me, when you think about 100 years, I can easily go to sleep and say, well, it doesn't really involve me. I won't be there. So I would like to suggest that as we develop the strategies, we actually look at the 100 years in blocks in the next 25 years. I think I'll still be around in 25 years. In the next 25 years, in the next 50 years, so that the strategy should be time-bound. We should have some goals for the next 25 years, some goals for the next 50 years, some goals for the next 75 years, and then some goals for the 100 years. So that those of us who are in this room and our age-mates out there take responsibility for ensuring that some things get done before the next 25 years. If we don't do them, if we don't start the process and we wait for it to be done in 100 years, we shall have killed our grandchildren. So I think if we make it in a blocked way, that way, then each of us will have a responsibility that we must achieve something in order to move on to the next level of the next 25 years. Thank you.
Let me ask you a follow-up, because if you look ahead 50 years, if nothing changes from the current trends, we're going to have this very strange situation where you said the pyramid. For one part of the world, here in China, for example, the pyramid is an upside-down pyramid. It's one little tiny point, and it's the one child. And then, dozens and dozens of older adults that will be dependent on that one child. The pyramid's upside down. If you go to Africa and many other places in the world where population is exploding, India, you have a pyramid in the reverse, yes. The classic pyramid. Yeah. Now, one pyramid, the upside-down one, has one set of health issues. And they're health issues related to the aging, to chronic diseases, management of isolated elderly individuals that this one little child on the bottom can't take care of. Yeah. And if you look at the other side of the pyramid, it's youth-oriented problems, sexually transmitted diseases, birth control and family planning, maternal mortality, all the issues for young reproductive adults. How are we going to have a world with these two wildly different demographics?
I think that if we aim at keeping everybody healthy, the problem won't be as bad as it might look. Because when you say elderly, usually it means people who are in their 60s and 65 and above, usually. But if people can be active and healthy into their 90s, then they may not need to be looked after so much as we might think. So even the one child one may not be overburdened if we keep the healthy actives. In other words, if we looked into issues of health promotion, disease prevention, and so on. And at the same time, if we look at the younger population, again, if we keep them healthy and empowered in terms of being informed and with skills and livelihoods and so on, then it may not be, it will be a challenge, but in my opinion, it can be manageable if the populations are healthy. If we achieve universal health coverage and people can be active into their 90s, and there was someone was saying here that even dementia, we can, what was it? Dementia, we can get rid of it. One of the speakers. So that it wouldn't be as bad as it is now. If nothing changes, it is frightening. And that's when I want to crawl into the corner and want to sleep so that I sleep forever.
Well, let me take frightening. Because the prior panel, I think, on balance, was rather optimistic. And there's certainly a way to look at this very differently. Ariel Pablos-Mendez is in charge of all health funding through USAID. And USAID is right now the largest or second largest public donor for global health in the world. I think PEPFAR is larger, but they're both US government agencies. I think you would agree that if you were doing your job right, if everybody in the donor side did their job right, you'd put yourself out of business because the recipient side would no longer need to be recipients, right? So the previous panel talked about this question of solidarity versus the lack of solidarity, of mutualism and shared risk, shared benefit versus a world that could be very disaggregated and very difficult. How do you imagine getting your job and your children's 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 world to a place where people like you don't have to do their job, and there is that kind of mutualism in the world?
Well, thank you very much. And again, thanks to the Rockefeller Foundation, where I also had a long history and affiliation for this opportunity. The question you raised is a question that has been at the very heart of the history of our work in this space and of the USAID. And just for clarification, USAID happened to program 60% of PEPFAR, so it's USAID plus 60% of PEPFAR. But the transition that you referred to was built into the DNA of the agency. When President Kennedy signed off the creation of USAID 50 years ago, he envisioned the ultimate day. He was an optimist, and I'm an optimist, and today will be also an optimist. Not only did he envision sending man to the moon in 10 years, but actually he could see the ultimate day, he called, when human progress will reach a stage of well-being, we heard, of human dignity, he said, in which we actually can satisfy our basic needs in the sense and the spirit that we have been referring to. So are we close to that? I said, yes, we are far closer than we can ever imagine. After 50 years, the gains that we have seen in child survival, in maternal health, in poverty alleviation, have been incredible. And that is now inviting us to imagine bold end games like an end to preventable child death, an end to preventable maternal death. And by that, I mean bringing the world levels of mortality of mothers and children to the range of the OECD countries today. This is not a slogan. This is actually pretty much happening right now. And we expect by the year 2035 to indeed see much of the world come at or below the upper range of OECD countries. So we are living in a very optimistic time when it comes to the health of the poor in particular, because that's where the greatest needs remain. We also, in the largest sense, there's an incredible process of development success. The agency had health at its heart all along, but it was a development agency, want to see the world get better economically and socially. And as such, we have also seen in the last 50 years an incredible transformation. After millennia of relatively flat income, even though income is only a partial indicator of the well-being of societies, but it was flat, that's bad. In the last 50 years, there's been a six-fold increase in income per capita around the world. And we have heard about the manifestation of that in emerging economies, and that has led to nearly cutting in half the number of people living in extreme poverty, and the trends keep going in this direction. Although we are suffering some economic pain right now in the aftermath of the recessions in the north, the world is actually moving in the right direction. And this has created a transformation in the economics of the possibilities for health, something that we have referred to as the economic transition of health. And it does mean that in the future, the economics of health will be more dependent on local resources, that is, countries themselves as opposed to aid. 10, 20 years ago, the majority of the countries that we used to call the developing world didn't have enough resources in their economies to pay for the basic life-saving interventions. Today, that has changed for the majority of those, not for all countries, but for the majority. Countries now have in their economies enough resources to cover basic life-saving interventions, and they're doing it. But the challenge will be redistribution, equality, equity, will be more of a challenge as we go forward. Globally, we are going to see a big convergence. Poor countries and rich countries of last century will have now closer and closer epidemiologic profiles, both in terms of decreasing maternal and child mortality and the decrease on chronic diseases. And likewise, the economics will begin to improve. Within countries, we need to pay a lot more attention. But what that will mean is in the future of aid is that, I mean, we are already closing missions in Latin America, Central Europe, Central Asia, because of success. Development is an incredible success. The development as a concept that the Rockefeller Foundation invented last century, before there was the World Bank, before there was World Health Organization, before there was USAID, there was the Rockefeller Foundation, science-based development for better humanity. And I think that we are now seeing the success of that vision through many new institutions. But for USAID, it means that 25 years from now, 30 years from now, our footprint is going to be hopefully very small. And in 50 years from now, I don't think we're going to have a job in the all development aid space. Certainly 100 years from now, there should not be aid in the way we construed, but actually more of the international cooperation and solidarity that has been referred to in the first session. So we certainly looking at that future. But this economic transition is universal. It happens that as your economy grows, your health expenditure will grow. We welcome that, as I said, in the emerging economies, because that brings resources for health. But the appetite for health does not stop there. And as the economies continue to grow in OECD countries, whether it's Latin America, Europe, everywhere else, we will continue to see health expenditure growing. And that will also bring its own challenges fiscally and politically around how to do this well with quality and equity for societies, as we see a future where maybe half of the US economy is invested in health before this century ends. And how do we manage that fiscally, politically, again, with equity, will be a challenge for the US, and it will be a challenge for every other country.
Another challenge. In the 1960s, in the health leadership in America declared that it was time to say that the age of infectious diseases was over. It was a tremendous optimism, and resources skewed towards cancer and heart disease. And then along came HIV, and now we've had 75 million people infected and 35 million dead. And it's the third largest pandemic we know of in the history of humanity. And this occurred when we said we could close the book on infectious diseases. There is always that possibility that we're being a little overly optimistic, thinking that we can now plunge straight ahead into the non-communicable diseases and imagine a world where we're structuring health around the needs of the chronically ill, the diabetic, the cancer patient, and so on. And along comes totally drug-resistant bacteria. That NDM1 mutation in India is terrifying. If it shows up in more species of bacteria, we will render more and more species basically untreatable. Or we could have yet another AIDS-like black swan appear. How do we move forward and at the same time maintain a healthy skepticism, preparedness? We had Tim Evans give one proposal for what a sort of global solidarity for pandemics would look like. What do you say?
Well, it was mentioned earlier in the session that when the foundation was established 100 years ago, germ theory was the scientific construct of the time. And out of that scientific construct, the Rockefeller harnessed that science to propel what became really the modern pharmaceutical industry with vaccines and penicillin and so on, as well as the world of molecular biology. But in addition, the Rockefeller Foundation, I think we heard earlier on about the wisdom of investing in people. And the Fresnerian medical revolution that inspired the Peking Junior Medical College and the modern public health that emerged out of the science of the time. So harnessing that science was paramount. And that capability has built-in flexibility to deal with the evidence and with problems that may be unpredictable. And we cannot close the books on infectious diseases. We have learned that much. And we will continue to be prepared to face the possibility of new pandemics and new emerging infections. I think the theme that I have heard early on from the various threats that we face in the world is the concept of One Health. And I think next week in Bangkok, there will be a conference devoted to the theme of One Health, where many of the ecological influence and health policies affect what happened in health. At the same time, Laurie, we cannot avoid to see the epidemiologic transition taking place. And while in Africa, still, we are in the initial paradigm, and it will take maybe another 10, 15 years before that transition happens in the continent and some of the poorest countries around the world, it is already the case that chronic diseases are emerging big time, and that we need to develop and harness the new sciences in chronic diseases and the new capabilities to deal with chronic diseases. One recommendation I will make to the Rockefeller Foundation is to look, I mean, there's plenty. We heard about brain, neurosciences will be important. We know from the new burden of diseases the importance of disability beyond chronic killers, chronic disease killers, disability that may not kill you, and yet that's going to be one of the most important burdens in the world in subtracting from the well-being of people and so on, and a future of healthy aging that you described. I think that one particular area that I think will be good for the foundation to focus is in the interaction between those changing patterns that we heard before, the biology that we are familiar with as we had at the new sciences of genomics, and particularly look at the epigenetics of the chronic disease, where the environmental factors interact in an adaptive way with our own biology in ways that are fascinating and could reveal new ways to deal, particularly because quite often the epigenetic phenomena may have socioeconomic gradients, putting the poor in a disadvantage, obesity being a case in point. So there's now a need to harness the new sciences and the new technologies, which could be more on the information technology and the physics as opposed to the biopharma technologies, to harness this power again. Science remains my favorite among the topics to deal with the new challenges of chronic diseases without closing the books, without eliminating the capability, having a robust professional bodies that can indeed be able to deal with both as the future calls for.
So parallelism.
Yeah.
I want to give a lot of time for the audience's questions. So, and unfortunately, they've already voted. But just really quickly, starting with you, Richard, is there one theme that really sticks out? Real quick answer.
Demographics.
Demographics.
Yeah.
Why? Real quick.
Because if I take Africa, we are going to see its population go from something like 0.86 billion to 1.92 billion by 2050. In some countries, the population is going to triple, like in Niger. That is unsustainable.
I bet you're going to agree with that.
Yes, I will agree with that and say that, therefore, one of the recommendations is that the world needs to pay a lot of attention to youth in the context of the importance of planned families. And not waiting until we are adults and married, then they start talking to us about family planning. But we need to invest in youth in terms of planned families. I think that is a need that would help us. In many of our countries, for instance, because of the tradition of the family handing land to the children, it's now a very big crisis and becoming a source of violence because the parent may not be able to pass land to all the children. So the whole issue of family size and is actually an urgent matter, not in terms of forced planning, but in terms of informed decision-making, beginning with youth. That's what my foundation tries to do, but we don't do much because of limitations.
Rachel Duan?
I actually would agree with Richard. I think it's demographics.
And then
how do you make technology relevant to the changing demographics?
Wow, I was expecting you to say science. Ariel?
I had already said science before, but if I may add one, I mean, demographic is destiny, and in a way, it's already figured out. And, but I think the economics of health are going to be paramount to how we are going to deal with both health and disease and the health systems in developing countries, in the all developing countries, and in now every nation around the world.
I'm going to disagree with all four of you, and probably with the audience, because I come back to climate change. I think it's number one. I don't think there's a health system in the world sufficiently resilient to stand up to multiple Hurricane Sandys, to stand up to the kinds of health challenges we've already experienced. I think if you're not paying attention to the fact that all the hospitals went, collapsed basically under Hurricane Katrina, and in a very rich country, the United States of America, you're not paying attention to what we're up against. I honestly think there's not a single hospital along a coastal region in the world that's ready for a 20-foot swell. And we're going to have a lot of them. And we've only seen the tip of the iceberg of what's coming. And I think it trumps everything else. But I'm sure that that's not how you guys voted. So I want to take questions now, and I want to leave a lot of time for your feedback, your response. And you have this extraordinary group to give your questions to. As you know, from the prior session, there's folks with microphones in the audience. And I can't see you, so I think a gentleman is standing up. Yes. Please identify yourself.
My name is Mark Royemamu. I'm from Southern African Center for Infectious Diseases. So it won't be surprising if I say something about infectious diseases. I do like Dr. Miriam Were's advice that we go in blocks, 25 years. I may have the same reason as her. But starting from that, I mean, one of the things we could take from lessons of today with respect to infectious diseases, where we know the vast majority of infectious diseases of humans are originating from animals. To begin with, we could drop the word zoonosis so that we can start outsmarting the pathogen.
Zoonosis.
Yes, we could do that within these first 25 years so that we can start outsmarting the pathogen, look at the pathogen, and not just simply at the clinical service.
Ariel, you touched on this when you were speaking of the One Health proposal. I'm sorry, were you finished?
My second point was what is happening now in one of the background papers Rockefeller gave us was referring to a changing society, which is going to be more and more heterogeneous, and whereby heterogeneity, in fact, it is going to be synonymous with rapid development, in the sense that heterogeneity is associated with the movement of talent. How is that going to play in the health system? Is it going to be, and I've got to be very careful because I'm standing between Chief Medical Officer on one side and Minister of Health on the other. They live on both sides of the same spectrum. One side works on heterogeneity by manipulating or managing immigration to bring in talent. The other side is part of the developing world where we go for homogeneity. Is that going to keep us apart? In other words, developing countries staying in homogeneity and therefore losing out on talent and therefore losing out on ability to address health issues.
Okay, I'm going to throw the zoonosis piece to Ariel, and I'm going to throw the immigration healthcare worker talent pool to Richard.
Well, little to add, but to recognize that that's, of course, a wise point, that many of those emerging pathogens and the ones that will come in the future come from the interaction between humans and animals. In the case of Africa, a lot of the wild animals. In the case of Asia, a lot of the domestic animals. But that interaction is paramount, and climate change affects that interaction, but also the socioeconomic developments affects that interaction, and looking at this in a holistic way is a wise way, which I think many in the world have been moving increasingly in this direction, with better science, with better monitoring systems, and slowly with some interventions that can help us deal with that. So clearly this is the way to look at the One Health paradigm is gaining traction. It's not new, some of the interactions, of course, but really the commitment to it that we have seen, and I think, again, Rockefeller and many others have been involved with this particular issue.
I would say, just personally, if I were to advise the Rockefeller Foundation on an interesting direction to consider funding, if we look at all of the most terrifying diseases that have emerged in the last 20 years, or that we've noticed for the first time in the last 20 years, almost all of them come from bats. And very clearly, bat populations are deeply threatened by a combination of deforestation and climate change. They are the great pollinators of the rainforests, but they're so stressed that they're coming closer and closer to humans and to our domestic animals. And so Ebola, Lissa, Hendra, Nipah, SARS, the list is very long. And we need to understand what's going on there because it's dangerous for us. Richard?
Well, on the question of talent, my very good friend Julio Frank and Lincoln Chen, and it was alluded to earlier today, chaired this commission on transformative health professional education. And
the Lancet Commission.
Yeah, and well, I wasn't going to say that, but it was, I think that did write a new chapter in the way we need to think about human resources for health. A new chapter that was based upon the notion of transforming the field of human resources. And I think that, I mean, two things I would say about that. Number one of the deficits of the MDG era, unanticipated, was that this huge focus on primary and secondary education, though of course it's absolutely right that we focus on primary and secondary education, meant that money came out of the tertiary education sector in many countries. And so you don't have those public health schools, those nursing schools, those medical schools, where you can actually train talent for countries. That was a massive, massive own goal of the MDG era, and it's one that we have to learn the lesson of. And I want to put in a plug for the next PMAC meeting in Bangkok next year, which is going to be on health professional education. And that's a fabulous moment and a very good timing in relation to the post-2015 discussions to come back to this issue of how do we want to build education capacity. And this point that Julio made in his commission report, we have in the health community paid insufficient attention to the intersection between the health system and the education system. And we have to bring the education system into our debate if we're really going to get this agenda right for post-2015.
Actually, let me ask Rachel Duan,
Yes.
because one of the shifts we're seeing is that some aspects of basic science and health technology are defying Moore's law. Genetic sequencing. Consider, 11 years ago, we completed the human genome, the first human genome sequencing. It took 10 years. It involved 160 laboratories. It cost $5 billion. And now you can buy a device and stick it in your kitchen. And for about $1,000, you can sequence your DNA on autopilot over a 24-hour period and know whatever you want to know. So it may, if you imagine melding what Richard was talking about with the ever cheaper cost of health technology, can health technology now be designed to require a lower level of education in order to do proper administration and proper use?
I think about this question in two levels. I think first is directly answer is absolutely yes. Okay, is like I said earlier, the high technology versus affordable, they are not in contradict with each other. Actually, making it affordable itself is an innovation, but many times a corporation, we just forget about the needs out there, that there is affordable healthcare needs, will tend to go after the advanced one. So I think absolutely, how do we make it applied? The second one, I'm just putting this talent question in the context of a multinational like a GE, okay? As the market is growing in emerging markets more, as we investing, like I talk about, in country for country R&D more, in China, for example, we're really envisioning the next 5 years, China for GE Healthcare can become a center of excellence for designing products in a certain space. Example, value segments for ultrasound, value segments for CT, value segments for MR. Okay?
What does that mean?
What does that mean? Value meaning affordable, basically, compared with ultra-premium segments. Because this is where the market is. Now, think about, as we are positioning China as we call it center of excellence, it really requires completely built out organization, including talents, okay? So today, we already have about 1,000 engineers in China, okay? But most of them are working as junior engineers as part of the global technology team, okay? However, to become an center of excellence for the value segments, we need more architects, we need more chief scientists, and that requires more investment and allow them to own more ownership of the platform. In many cases, we send them over in US and train and come back. So I actually see it's a bilateral way of inflow of talents, both from developing to developed and backwards, because each has a different roles to play. So I still envision our US will become the premium COE center of excellence for a lot of technology, but I can envision China and India will become really the COE for our value segments, and our talents are building accordingly.
We have a question here.
Srinath Reddy from India. In the 20th century, a great many mechanisms were evolved to protect intellectual property, including in the area of science and communications. Now, in the previous session, we have heard a great emphasis on solidarity and global health as a common good. When tensions arise between proprietorial science and ready application of the products of science for global health, how do you see new social contracts evolving to address those tensions? And what will be the levers for those?
So we're to the IP question, the intellectual property question. And Rachel, I'm afraid that's yours.
I think the ultimate protection of IP is to develop the next generation technology. Okay, you can't just, many times we debate about, should we do this technology, import this, or develop this technology in a developing world in China, for example, maybe the infrastructure for law is not as advanced. But eventually, whether we like it or not, there are going to be local competitors who are going to do that. Okay, it's a matter of time, they're catching up. So to us, the ultimate protection of the IP is we continue to really get on to the next wave of the technology invention. Now, having said that, in cooperation, then we're also looking at how do we establish our processes and then policies to making sure in the technology we put it in a country like China are well protected.
Okay, now in the back here, yeah, there you are.
Thanks. Laurie, I think I have two comments. One of them is your point around climate change and the concern many of us have with sustainable development being pitched with the environment against people. And particularly, every effort to improve well-being could have environmental implications. And at the end of the day, how you balance that becomes very critical. And most of the countries that have developed, I think there's been an impact on the environment. And how can developing countries like Africa currently achieve high levels, improved well-being without an environmental impact? And I don't think we have a model for that currently. So when we put focus on climate change and at the expense of people, then it creates this disconnect in our development.
Can you explain why you see putting climate change as at the expense of people? People will die in climate change.
Sure, but at the same time, most of the actions that you would take to preserve the environment may also, if you invest more in people and there is improved socioeconomic development and things like that, it will lead to a certain level of lifestyle and consumption that may actually affect the environment. So at the end of the day, that's a challenge. And the question is, where should that investment focus? And it's not one versus the other. I think it has to be both people-focused, but in a way that also sustains the environment. The second point I really want to make is to underscore the point of demographics. One of the points that we've not brought in is, if you look at Africa, maybe close to majority of the health production is actually at the household level, with the household bearing the major cost of healthcare, both in care and in support and in other ways, financing and all that. Currently, with the demographic shift, the concept of household is actually losing its meaning. If you go to Southeast Asia, for instance, in South Korea, a single person household is actually accounts for more than 50% of the households currently. 10 years ago, 4-person household was the majority. So with the shifts now and the migration that comes in, even when you have strong families, they are in different continents and different parts of the world. How do we maximize this role that the household has played over the years in the provision of health.
Thank you. Because one of your comments was thrown to me as moderator, I'm going to defer because I want to give the panel an opportunity. There were two things that I'd like to throw to Miriam Were. This demographic question he was asking about households and their ability to be resilient in the face of the transformations of what's happening with the family. And Ariel, he mentioned the bankrupting cost of out-of-pocket expenses. I wonder if you'll comment on that and how you imagine that being improved going forward in future decades. Dr. Were.
I think some things are just realities. For instance, the changes in family size, which result from smaller sizes or, as you say, people living in different continents. So I don't see why that should lose the meaning of households. I guess it depends very much on how you define households. If a household is a unit that stays together, it can be 2 people is a household. So that idea will still be functional, and one can still deal with the household. So I didn't quite get the problem.
It is a real challenge, obviously, and if you imagine in a very basic poor setting, poor community, when you have indeed a household of 4 or 10, there's not a lot of cash. Most of that is subsistence, and people help each other. You don't pay for things, you help each other. That's all you have. And selectively, you can bring some interventions from government or donors and so on to help out. And we heard before from Sudhir that looking at catastrophic out-of-pocket expenditure may not quite give you a sense as to whether those households are having real access to communities. And that is true. But the economics of most of the households are actually changing. And as societies begin to develop cash and societies evolve, and this is what happened, then you start having the situation you referred before. Eventually, you lead to households where you have only one person, or you belong to virtual communities, which are not all that helpful when someone needs to need feeding you or changing you or something like that. And so that means the demands for new social constructs to address those needs will have to change, and it's been changing everywhere. How we pay for those are political issues, economical issues, and in health, it tends to be, by default, paying out of pocket. And for many other well-being services, tends to be out of pocket. But of course, out of pocket becomes very both inefficient and regressive. In the United States for health, right now we spend about $8,000 per capita. So a family of 5 spends $40,000 per capita in a society where the median after-tax income is $40,000 per capita. So if that's the median, that means half of the population can only pay for their average expected expenditure and have nothing else. And of course, many will not even have that. That really creates challenges of how we organize the services, because on the whole, spending $8,000 per capita should allow us to do a lot better than we end up in some cases. So organizing the health systems, organizing the financing, the theme of universal health coverage, which in the United States now is the law of the land, moving to universal coverage is a much rational way to deal with the service provision, which increasingly include other support services that may address some of the fact that when you are in need and you live by yourself, there might be some arrangement. But we need to plan for it. We need to pay for it in a way that is efficient and equitable.
It's a little shocking that in the United States in 2010, 2 years into our foreclosure crisis, medical bankruptcy was the #1 form of personal bankruptcy in America. A gentleman here had a question. Please identify yourself.
So, I'm Jack from the PATH. So my question goes to Rachel. Yeah. So today we are talking about the trends. So through your strategy, I see the trend that from the pure importation to the local R&D is very good. But we see China change its role from the recipient to the resource partner. So in China, we have been working with our partner to develop products to benefit not only vulnerable population in China, but also other poor countries. Yeah. So my question that have GE considered this kind of in China, but not only for China strategy?
Absolutely. So that's why we say we call it globally in country for country, but in China, I would like to call it in China for China. In fact, as we're evolving from developing product for China and for China markets, what we find is many of these products are very relevant to the other emerging markets. I'll give you example. The CT example I just mentioned, we launched 3 years ago. 50% of the output is actually exported to the other emerging markets. So our CT plant in Beijing, not only making that serving the rural county hospital in China, but actually it's selling it to Latin America, Africa, and Southeast Asia. And as we are evolving our in-country for country strategy to a more COE, Center of Excellence, this role for China to play is not just going to be serving the China market, it's going to be serve the rest of the world. And eventually I can see this ICFC become the ICFW, so in country for the world.
We had a question over here. Who had their hand? There we go.
So thank you very much. I'm Fred Binker from Ghana. I see a little bit of a dichotomy between where we are now and where we are dreaming to go in the next 100 years. It's as if everything is finished, we've solved it, and we're thinking about how to get to the next stage. But I thought that two issues that were raised links the current with the future, and that has to do with the budget and public sector reform. Because the benefits of science that we have today, the interventions and so on, if they were really deployed, I mean, we will have such great impact on human life. But we all know that that's not happening. So in a way, there's a kind of a disjoint. So yes, we dream into the future, but there are lessons we have to learn that improvement in science and others may not necessarily transform into what we expect. So how do we link these two, and what are your comments about that?
Ariel?
Well, the Rockefeller Foundation has been a leader in really framing at the global level, because it's been happening in countries for a while, the idea of universal health coverage. It's a way to organize the growing domestic resources. Science is growing, and so are the economies of countries. But by default, they are not going to be organized in the best possible way, neither in terms of efficiency or inequity. So developing systems that can deliver universal health coverage, which includes public health and medical services with efficiency and equity, is indeed the challenge. And it is a dream, as we heard from Judy this morning, that is now being dreamt around the world. But it's an early dream. We need to really see that through, and the challenges will grow. We need to learn. We need new sciences for universal health coverage. It requires a lot more intelligence in health systems, better health economics, and education, because a lot of this is about understanding. Oftentimes the debates are based on positions of philosophy or positions of interest, when indeed there's a science to show us the best way forward, as we have seen in the biological sciences, so too in the economic sciences of health. We need to have that clarity. But I think universal health coverage will be a way to bridge our current concerns with the future concerns, whether it is the old infectious diseases or new infectious diseases or new chronic diseases.
Okay, we're down to our final seconds. And I think I want to say, first of all, that it's extraordinary that the Rockefeller Foundation is with us 100 years on, and will hopefully be with us another 100 years, that they organized this event, and that we had geniuses like Dr. Miriam Were, Dr. Ariel Pablos-Mendez, Dr. Richard Horton, and CEO Rachel Duan with us. Let's thank the whole panel, please.